The inspection portion of the exam starts when either you have the patient ambulate from the waiting room to your exam room. If they are already in the exam room, it would be important to watch them walk. And so you're going to observe the patient's gait, looking for any limps or any deviation, both from the front and from the back. He's going to walk on his toes, and then he's going to walk back on his heels. And then let's do our hip portion. We're looking for any weakness of the hip musculature. And to do the Trendelenburg sign, you ask the patient to lift one leg off the floor. And if this musculature is weak, this pelvis will drop down. So again, we're testing the integrity of this musculature right now. And you can do that for up to 30 seconds. But if they have pain or you see a change, you can end it as soon as you see that. You would then do the next leg the same way. Again, now we are testing this side, and if this musculature is weak, this pelvis will drop down. And again, you can do that for up to 30 seconds. We'll move on to the palpation portion of the hip exam. This can be quite of a sensitive area for the patient, and so you need to warn them that you may be touching some sensitive structures. The other thing that comes into play is how to appropriately gown your patient, whether you need to have bare skin or whether they need to be covered. Each situation is a little bit different. For demonstration purposes, we'll leave this patient in his underwear, and we'll cover his sensitive structures with a sheet. We will start with the anterior portion of the palpation. The first structure you're going to look for is the anterior superior iliac spine, which is the origin of the sartorius muscle, which runs from this direction. And so this is the ASIS. Then you're going to move down inferiorly and medially, looking for the anterior inferior iliac spine, which is the origin of the rectus femoris muscle. This is not always a discrete structure that you feel, and to bring it more prominent, you can ask the patient to do a straight leg raise, and you can feel the rectus femoris muscle engage. So the ASIS and the anterior inferior iliac spine. The final structure on the anterior aspect is the pubic symphysis, which can be quite tender, but you move down to the bony prominence right here, and you're looking for any tenderness on the pubic symphysis. Next, we'll move on to the lateral palpation portion, and you would ask the patient to lay on their asymptomatic side. You're going to specifically be looking for the greater trochanteric region. So that is the bony portion of the femur where the greater trochanteric bursa is, the gluteus medius muscle inserts, the gluteus minimus muscle inserts, the piriformis muscle inserts, along with some of the other external rotators. And you're looking for tenderness at that bony prominence. In addition, you're going to be looking for the iliotibial band or tract, which goes from proximal to distal down to insert on Gerdy's tubercle on the tibia. And so you're looking for any tenderness along the iliotibial tract. That will complete your lateral portion of your exam. Then you would ask the patient to get in a prone position to feel the posterior structures. The posterior structures that you will be examining are the posterior superior iliac spine, which is a bony prominence, which for all intents and purposes is the sacroiliac joint. You would compare both sides, but that's the PSIS. Then you would palpate the piriformis area, which is really in the meaty portion of the buttocks, and noting that the sciatic nerve is right here too, and so you're feeling at the piriformis area. And then finally, you would try to palpate the origin of the hamstring muscles, which is ischiotuberosity, which is deep inside the gluteal crease. And that would complete the palpation portion of your hip exam. Next, we will do the range of motion testing for the hip. We will first do flexion. Flexion can be done with two different positions, one with the knee straight, so ask the patient to flex their hip. Again, this is active. And then ask them to bend their knee, and that is flexion with the knee in a flex position. We would do extension next, but that will be done with the patient prone, and so for purposes, we'll move on to abduction, abduction, which is away from the midline, and then adduction is towards the midline. Then the next tests are extremely important, and those are internal and external rotation, and there are a variety of ways to do that. One is simply the log roll test, where we're turning the ankle in, and that would be internal rotation, noting that any pain inside there would denote problems in the actual true hip joint. So again, this is internal rotation. This is external rotation. You can also do that with the knee flexed. in which case this would be internal rotation or the fader test, flexion, adduction, internal rotation, and then followed by the Faber test, which would be flexion, abduction, external rotation test. This test is also called our figure 4, our Patrick test, and we will do that in our special test. Finally, you would complete the exam by doing extension, and you would have the patient go in the prone position. And I would ask the patient to extend their hip. And while they're here, I would ask them to resist me, and that would be resisted hip extension. Can you roll back over, please? You would move on to your strength portion, and all the strength portion would be is to resist those range of motions that we just did. And so ask the patient to bring their knee to their chest. That is resisted hip flexion. Ask them to abduct their hip. That would be resisted abduction. Ask them to adduct. That would be resisted adduction. And we don't really do a resisted internal or external rotation. Test active hip abduction. You ask the patient to abduct their hip. You ask them to leave it in the air as you provide force. This tests the hip abductors in the iliotibial band. Bring the patient back down to neutral. Another test for the iliotibial band is called the Ober test. To do the Ober test, you would stabilize the pelvis, you would flex the knee, and then you would just let the patient's leg drop and see if it goes below the midline. Patient who has a tight iliotibial band would not be able to drop that leg, and it would stay tight up here. A modified version of the Ober test is without knee flexion, with a straight knee, and again, seeing if the tightness causes the hip to be unable to adduct. That would complete our range of motion and our strength testing. Next, we would move on to our special test. Our special tests are really a combination of some of the tests we already did, and one would be the Thomas test. In the Thomas test, the patient actually tries to bring their knee to their chest, and you're looking for any quadriceps or hip flexor tendon tightness. And what would happen is that they would elevate the leg, the opposite leg, or they would have an exaggeration of their lumbar lordosis if they had tightness in the hip flexors or the quadriceps. We will show a modified Thomas test after we complete a couple other tests. The next test we would do is the Fader test. We actually already did this, flexion, adduction, and internal rotation, looking for any pain inside the hip joint itself. Finally, we would do the Faber test, flexion, abduction, external rotation, and we would exacerbate that by pushing down on the knee, stabilizing the pelvis, looking for any pain in the hip, or looking for any pain in the sacroiliac joint. Next, we will do the modified Thomas test. To do the modified Thomas test, the patient grabs the leg, brings it back to their chest. All right, so you're actually looking, this is normal, this is normal. He's not abnormal, he's tight here, okay? And then if this doesn't stay parallel, that means he's tight in his hip flexors. So if his leg moves up here, his quads are tight, and then if his leg comes off the table, that means that his hip flexors are tight. And so we would look here, with this being normal, and this is abnormal, and then we would look here with this being normal, and he's a little bit abnormal because he's tight. Hip extension can be done in a variety of ways. While the patient is prone, you would ask the patient to actively extend their hip. And then if you wanted to do a motor portion of it, you would say, resist me as I push you down, and that would be resisted hip extension. We're going to evaluate for leg length discrepancy. The way to do that is to perform the following maneuvers. Have the patient bend their knee, fix their feet to the bed, have them bring their hips up in the air, bring it back down, then straighten the legs out, and you're looking to see if both medial malleolus are roughly the same. If you are concerned that they are not roughly the same, then you'll measure it, knowing that there is something called a true leg length discrepancy and a functional leg length discrepancy. A true leg length discrepancy usually presents much earlier in life, whereas most adults, if they have one, is a functional because the pelvis is rotated. If you're evaluating for a true leg length discrepancy, you need to go from bony point to bony point. So we would go from the top of the ASIS, anterior superior iliac spine, down to the bottom of the medial malleolus. You would get that length, and then you would compare on both sides to see if there is greater than a centimeter difference. For a functional abnormality, you do a fixed point, which we use the umbilicus, and you measure from the umbilicus down to the medial malleolus and see if there's greater than a 1 centimeter difference. with the umbilicus down to the median malleolus being functional, and a fixed bony point to a fixed bony point being a true leg length discrepancy. If you are concerned about a true leg length discrepancy, you would get an x-ray called a scanogram, which would measure the length of the femur and the tibia and would compare the two to evaluate for a leg length discrepancy.